Hello, welcome to another in a series of video learning modules with the Mother's Mental Health Toolkit project. I'm Dr. Joanne McDonald and I work with the Reproductive Mental Health Service and Halsey University here in Halifax, Nova Scotia, Canada. The module that we're going to look at today is really what is the spectrum of severe and persistent mental illness in mothers. This is really a big topic, and we'll really only be touching on it somewhat, but we wanted to give you some sense of what we see in the mothering population around some significant illnesses. When people talk about severe or persistent mental illness, they're really thinking often about the diagnosis of schizophrenia, of bipolar disorder of particular severity, and postpartum psychosis in the mothering population. And really, there's a bit of a sense that you're going to recognize someone when they've suffered with a severe mental illness, that it will be obvious, that their behavior or their emotions or their life will seem very different than yours. But that's not always the case, particularly with good treatment and good supports. Your neighbor may be struggling with a significant medical problem related to severe mental illness diagnosis without there sort of being obvious signs. So one of the key points to understand is that just like some people struggle with arthritis or headache or other problems that we can't see, that mental health problems really aren't always visible. And that's part of what we want to sort of help the community understand how this may impact on mother. So some key concepts right from the start. Mothering is a socially important role for many women, including women with physical and mental health challenges. Mothering with a previously known or new, more severe mental disorder, though, can be very challenging, as you can imagine. Again, just as if you were affected by a serious physical illness at the same time you were trying to take on this new role of mother, you would find balancing those two demands considerable. And so this is true for women with mental health challenges as well. Support, both practical and emotional and psychological, from partners, family, and the community generally, is critical to how the affected woman, though, will function as a mother. This point can't be made sort of strongly enough. In almost every formal research study, when you look at outcome from significant mental illness, sure, treatments are very important to evaluate, and other factors, risk factors, may play a role, but critical to outcome is the level of social support. Women with severe mental illness, though, can mother safely and effectively with this kind of effective treatment and support. Let's look at schizophrenia in particular. Well, schizophrenia occurs in less than 1% of the general population, so it's a not common problem, but a really often severe illness. It's partially understood, though, in terms of why and when and how it affects this particular person. It's thought that there's some vulnerability that actually may be triggered earlier in the person's life that doesn't present until usually early adulthood, late teens. So just at the time that many women are coming into so-called childbearing years. It's a brain illness that has a spontaneous onset, and there's really nothing we believe that people do particularly to bring this illness on themselves. Like with any other health problem, but particularly mental health problems, stressors, challenges to brain function with multiple substance use, tremendous strain, loss of sort of sleep, and other sort of biologically important restorative experiences can certainly seem to be part of the picture sort of in the first onset of the illness. But fundamentally, this is not something people cause. Prominent symptoms can include a kind of slowing down, a loss of initiative, a lowered attention really to real life experience, and reduced thinking generally. So people close to the patient will often say, there's just something subtle I noticed first, that they just didn't seem to be themselves, they weren't responding as often as they would verbally. They just didn't seem to be kind of with us in the same way. It's like they went internal in terms of their own thought. But yet when you'd ask them, what are you thinking about or what's going on, really they'd say, well, kind of like nothing. So this is the so-called negative symptoms of schizophrenia, which can be found in sort of a kind of dampening down of normal pace of thinking, normal content of thinking, and normal reactivity socially. This may also come out in that planning and decision making may be particularly different for the person as the illness progresses. They may have unusual ideas that they seem more fixed on. They don't always make sense. They're not always bizarre initially, but they often can progress on to have a suspicious theme, or the affected person may begin to think that ordinary events have particular meaning for them or a particular influence on them. Not always, but often there can also be associated abnormal sensory experiences that we call hallucinations, in terms of visions of things that others don't see, hearing things, feeling things, experiencing things at a sensory level. And fundamentally a change in personality and behavior for that person. It tends to not be dramatic, although sometimes sudden illness can occur, but these changes tend to occur sort of more gradually over time. As you can imagine, the impact on the person's function is great. So think about, again, trying to mother with this as a new onset illness or even as a previously known illness, but one that challenges your day-to-day life and your ability to sort of enjoy your life, interact, and work, handle tasks, and have a sort of satisfactory mental and emotional life. It's also important to remember, though, that women with schizophrenia and other severe and persistent mental illnesses, when we follow them over time, they really, because the illness often has such an impact and begins at a relatively early age, these women are really affected in terms of their education level, their employment possibilities, their social opportunities generally, and tend to live in more challenged neighborhoods with poorer housing. So these are all the social determinants of health that have a lot to do with sort of outcome, generally economically and socially, but certainly even in terms of health outcomes, we know go beyond diagnosis. So they experience poorer physical health than unaffected women when followed over time. So family support and staying connected with a functioning family is really critical to parenting potential and stability in these women. Obviously the health and the function of the partner, if they're present with this woman, also is a factor to consider. So some people will leap to judgment that woman has a diagnosis of schizophrenia and not have a sense of how stable she might be, and think, how can she possibly parent with that illness? Well, you have to remember there's another parent sometimes present in the household, in the family, and there may be considerable support and understanding of that woman's mental health challenges, and a lot of encouragement towards the normalizing role of mothering. Pregnancy is not always planned for anyone, let alone people with a mental health diagnosis, but mothering may be a very wanted role. So again, let's talk a little bit more about how severe mental illness may sort of look with mothers. What do we see? Well, what about treatments? Key to recovery usually are antipsychotic or other psychotropic medications. It's rare that a person can recover from severe and persistent mental illness without medication or other treatments. So particularly the safety of those medications in pregnancy and their use when breastfeeding must be carefully assessed in new mothers. However, surprisingly, sometimes the outcomes for infants exposed to medications in modest amounts, and good monitoring and careful choice of the medications can be very good. And additional therapies and parenting support and education in the postpartum period is really important to try and prevent relapse at this time. Again, getting a bit repetitive, but family and community support is a key determinant of outcome. What about bipolar disorder? Well, this is a complex disorder, but the simplest way to think of it is that, it is a cycling of different phases of changing mood and behavior, from low or more depressive in character presentations to high or more over-energized states. It's highly variable in severity, so simply knowing that someone has a bipolar disorder diagnosis doesn't really help for sure, kind of what the level of risk might be or what the impact on function might be. So that may be an important area of inquiry, is how long have they had the diagnosis, what's their treatment experience been, how do they achieve stability, do they feel they've had that, kind of get a sense of the where they fit in a severity spectrum. Symptoms can vary from woman to woman, though, and in the same woman over time, and this traditionally makes diagnosis very difficult because it's easy in any particular phase to attribute what's happening internally, mentally for the woman and in terms of her changed behavior as just simply a reaction to the demands of the day. And that's why there can often be weeks to years of delays in diagnosis until you really see that pattern. Key is that the mood and behavioral state can change quickly without always an understandable trigger, and that there isn't that stability of long periods of function kind of in the middle, that there is this variability. So often women will be encouraged to keep sort of a mood, behavior, and daily kind of chart or rating of various types to sort of have a sense of what her pattern is over time. There are three diagnoses along the bipolar disorder spectrum. One is called cyclothymic disorder, and that just really refers to a milder up and down of mood, fluctuating mood states, minimal triggers, and less impact sort of on function. Bipolar 1 is the typical bipolar disorder illness in which there are sort of equal severity of the high and low phases. Now, that's not to say that one always switches from high to low in a predictable pattern. There may be periods in their life when one or the other is more predominant, but again, over time, looking at the pattern, they experience both phases of the illness. Bipolar 2 spectrum is really referring to a variant of bipolar disorder where we see predominantly depressive changes, and that the high phases tend to be not quite as extreme as we see in bipolar 1, harder to recognize, and again, sometimes just put down to sort of a couple of days of increased sort of productivity and creativity. And really the woman and the people around her focus on the impact of the depressive phases. But approaches to treatment of bipolar spectrum disorders are very different than that of sort of isolated depression or anxiety. And so it may be a very important aspect of assessment to get some sense of whether we do have a cycling mood disorder rather than from normal to depressed and back again. So a key concept here is that women with known bipolar disorder are really at the highest risk of relapse in the first 3 months after a baby is born. This is thought to be related to sleep deprivation, changes in rhythms, possibly hormonal triggers, and that bipolar disorder in general, on our second concept, can be very influenced by women's hormonal changes. So we see this with women outside of mothering in terms of premenstrual worsening of symptoms or onset of illness, periods coming particularly at certain times hormonally. Family history can be a very key risk factor. So the woman herself may not have a known diagnosis, but if there are other people in the family with a pretty established or high index of sort of consideration of a bipolar diagnosis, we tend to try and watch those women a little more carefully in the postpartum. We'll often try to sort of increase the self-care, particularly sleep, and assistance with any young children or infants, to really try and be protective of that woman in that first 6 to sort of 12 weeks. So what are some of the features of bipolar disorder? Well, the higher up phases tend to be marked by increased speed of thinking and sometimes actions. Ideas can be a bit impulsive, to sort of, at the worst, presentations more frankly irrational. There can be rapid shifts in attention and thinking, so the person will sort of jump from topic to topic or idea to idea, and their thought connections sometimes seem really pretty kind of loosely connected. The mood can be very excited, and sometimes people can seem kind of euphoric and fun, life of the party, highly energized people. That's the positive side of the high, but at other times they can seem scattered, disruptive, and can progress to sort of irritability and high reactivity. Their decision-making and judgment, though, is often off compared to what their sort of normal in the middle kind of thinking would be on a given issue or situation. The depressed or down phases are marked by slowed thinking, sometimes a very kind of deep fatigue and a sense of heaviness physically. People will talk about saying, I feel wooden, I feel like lead, like I can't sort of move my arm off this couch. The mood can be suddenly plummet to a very low level. And again, the person who was sort of, moving around quickly, doing a lot of things, having a lot of new ideas, can suddenly not seem to even dress themselves in the morning. So initiative sort of just falls dramatically. And out of proportion to the realistic circumstances around them, they can become very hopeless with very negative thinking, sometimes even plummeting to sort of sudden and unconnected suicidal or self-harm ideas that they may even themselves be able to say, I get these thoughts and I have no idea where they come from. I didn't feel this way, last week, and it just feels really sort of forced and foreign to me. So dramatic shifts in the more severe illness forms from these two states. Usually over, a few days to a week at a minimum at a time. Rapid shifts in mood from hour to hour within the day are sometimes not always bipolar disorder, but indicative of other kinds of emotional regulation and coping problems. But that distinction can be tough to make and is often why it's important to have ongoing mental health evaluation and assessment. So what about interventions? Well, as I just said, expert mental health assessment is very important, and even if it's difficult to access or takes time, can be a very important part of limiting the distress and dysfunction in that woman's life. Again, never hurts to minimize stressors. We know this particularly has a role in mood disorders and improve self-care, particularly sleep and daily routines. So some recent research on known bipolar disorder outcomes suggests that so-called biosocial rhythms are really an important component of stabilization and wellness. So it's not just nice to have a routine and nice to go to bed early. It actually makes a difference in outcome. Stabilizing medications may be necessary in the short term, sometimes in the longer term. Again, that may vary from patient to patient and depends somewhat on the severity. But we really encourage people to be open to the role of medications because it can be that factor that really allows the non-medication strategies that that person and their family can do to really heighten wellness and stability. Getting old again, repeating myself, but family involvement, education, and support, again, are very key to recovery in bipolar illness. But with effective treatment and supports, that recovery can be very solid. So many people live very well with a bipolar disorder diagnosis. They just don't wear it on a t-shirt and you may not know about it. Medication may be necessary, and self-care strategies, again, are key learning points. What about postpartum psychosis? Well, this is a very rare but severe and sudden onset disorder usually. It occurs in 1 in 1,000 women delivering a baby may present with postpartum psychosis, compared to, say, 1 in 10 women who might experience depression. Sometimes the classic form of this comes on very rapidly over, 24 to 48 hours. So, when early symptoms are seen, it's important to take it seriously and consider the possibility in a new mother that, this is an emergent psychotic illness for her. Not the role of most community providers, obviously, to diagnose or to intervene and treat in this severe illness. But, again, it behooves us all to sort of have a sense of what the risk may be. What are the warning signs? Well, sudden changes in awareness, attention, and memory. Some women have been described as having kind of a dreamy, confused quality in the few hours before the onset of postpartum psychosis. They can be preceded by an excited and sleepless period when, again, their behavior is not typical for them, but maybe put down to the excitement of a new baby, lots of visitors, not delivering at a time where they don't get a lot of sleep over the first 24 to 36 hours. But the behavioral change is really dramatic from that woman's usual character in interactions. Her thinking and behavior may begin to not make sense. they're not connected to the current situation, and she may again have those core psychotic features of unusual or suspicious ideas, or ideas that don't make sense in a conventional way, aren't connected to what's happening around her, and again have hallucinatory or other abnormal sensory experiences. Not always do women with psychosis progress to overt hallucinations of a visual or auditory nature, but they may have what we call illusions in a really persistent way. So they constantly think there's a sense of someone moving, or they think in a busy hospital unit that people talking in the hallway outside are talking about them, or they think they hear people talking, mumbling, when other people, sitting in the room with them don't hear that to the same extent. So there's a heightened sensory kind of awareness, and this idea, again, that these experiences have particular meaning or influence on them. So key concept number 3 is that postpartum psychosis is a medical emergency and requires urgent psychiatric assessment. I always encourage community members, family, the women themselves, that if they feel something is profoundly changing and the woman is looking really disorganized, very much not herself and very ill, well beyond what we'd see with typical sleep deprivation or the early superficial emotions of having a birth, it's okay to be wrong. More important that you have that person present to an emergency room service for urgent assessment, find out that you're dealing with something else, or that they just require some monitoring, than that we miss sort of this severe level of illness. Treatment often requires initially inpatient care for true postpartum psychosis. They typically need antipsychotic medications, and they, ideally should have ongoing mental health care and follow-up for monitoring even after the immediate symptoms seem to settle. This may be with a family physician, nurse practitioner, or other primary care provider with backup from a mental health team, but ideally there would be mental health expertise involved. The safety of the infant or any other children needs to be carefully considered at all phases of the illness for this woman, but most women recover fully with treatment, though it may need to be considered that the medications used and the treatments themselves may not be safe for an infant who is being breastfed. So again, that's often where the role of mental health expertise comes in to decide what's the best approach for this woman and this family that will ensure the safety for herself and her children, but also really enhance rapid recovery for her. Sorry, I want to bring you back to this slide to remember that severe illness of any sort, but particularly severe mental illness, interrupts the mothering role and the ordinary adjustments, which are considerable. So these mothers need particular support and hopefulness for their full recovery. And it needs to be, done from a careful but also positive place of advocacy to understand that many women, even with severe mental health problems, can mother effectively and safely and meaningfully with the right level of supports and treatment. So our key learning points again overall in this module are that the role of community support providers really in these illnesses is to include continuing support to the mother and adjustment over and above the effects of illness, and that despite illness it's important to reduce stigma and provide a sense of inclusion in the community of mothers. So many women, for instance, who have had postpartum psychosis really step outside of their lives, really require a lot of additional family assistance, maybe with the infant care while they're in an inpatient setting. And so they kind of come back to the mothering role some weeks or months after everyone else has been through certain kinds of adjustments with that child. And sometimes it can be forgotten that there's really a gap for them in their mothering knowledge and their mothering experience, and they may need a lot of support and encouragement to realize that they can make up that ground, that all the way through, even though they're not feeling fully themselves, they can continue to work on attachment and connection to that child, and that self-care support and strategies over the long time are key to recovery from severe illness. So once the person's immediate symptoms are better, sometimes it's easy for all the supports and all the routines to sort of fall fall away, but particularly for these diagnoses, it may be important for women's well-being long-term and the stability of that recovery, that sleep, nutrition, respite activities, rest, social support are really continued for quite a long time, sort of for months after that initial diagnosis or illness, to make sure that she stays well and has good strategies sort of going forward. A couple of key resources for you related to severe and persistent mental illness are the Canadian Mental Health Association's website, which is a very broad source of information for patients and families, an important advocacy organization in this country with information on a wide variety of mental health problems. I'd also direct you a bit to postpartum.net, which is an American-based patient advocacy site where a lot of really meaningful personal stories and information are shared. And so even if a woman can't meet another person who's gone through a bipolar illness or other more severe mental health problems, she can also identify with the stories and the personal aspect of this patient advocacy site. As well, there's a lot of links to sort of current information in the field, a lot of self-management and self-care strategy recommendations. Just important to remember for countries outside of the United States that it is an American-based resource. And so we may have to look a little further within our own country or region for direct resources. Thanks again for your time and attention to one of our video learning series. We hope that it'll help support your work with women.